everybody. I'm Dr. Ashok Chacko, presently the head of medical gastroenterology and chair of internal medicine at the Naruvi Hospital, Vellore. I'd first like to thank Dr. Manoj Sahu and Dr. Avinash, as well as the organizing team of the MIDTERM GI, for inviting me to speak on capsule endoscopy of the small bowel. It was Gabriel Leighton from Israel and Paul Swain from the United Kingdom who first pioneered and discovered the technique of capsule endoscopy for evaluation of small bowel disease. In 2000, FDA approval was given, and the first publication on this subject was in Nature in the year 2000. Going on to the components and design of the capsule, it consists of three components. The capsule itself, which has got an optical dome, a light source, a lens, a complementary metal oxide semiconductor imager, CMOS, battery, a wireless transmitter, the ASIC transmitter, all packaged into a small capsule. The second component is the data recorder and the sensor pads. And the third is a computer workstation with software for processing and displaying the images from the data recorder. Presently, there are 5 capsule endoscopy systems available. The PillCam, which is the first system from Given Imaging Israel, the MiroCam from Intramedic Korea, EndoCapsule from Olympus Japan, CapsuCam from Capsule Vision California, USA, and the OMOM capsule from China. Let us look in a little detail regarding the various characteristics of these 5 capsules, which may help us to understand them better and also help us to choose which capsule endoscopy system to use. Essentially, when you look at dimensions, all are almost similar, except OMOM and CapsuCam, which are a little bigger and consequently a little heavier. The field of view of PillCam and MiroCam is about 170 degrees, whereas for EndoCapsule and OMOM, it is about 140. The CapsuCam, which has 4 cameras, has got a field of view of 360 degrees. The frames per second is on average 2 to 3, whereas the recent PillCam has got a frames per second of 2 to 6, which means if the capsule moves faster, the frames would increase. And the CapsuCam has about 20 frames per second. The image sensor used is the CMOS for all except the EndoCapsule, which has a CCD chip, and the transmission is by radio frequency in all except MiroCam, where it is a human body communication. CapsuCam does not require transmission because all the images are stored in the capsule. And consequently, when the capsule is excreted in the feces, it has to be retrieved using a magnetic wand. The battery life is around 12 hours for most capsules. So which system to use? There are few head-to-head trials of one capsule versus another, but whatever few trials we have showed no significant difference in diagnostic yield or completion rate. So the capsule that one would use would be determined by user preference, the cost, and the availability of the capsule. So before the procedure, we need to prepare the patient. The best preparation to date that has been shown to date is 2 liters of polyethylene glycol preparation on the night before the study, and simethicone, an anti-foaming agent, to be given before the study is also helpful in better visualization. What about prokinetics? Is there any benefit in giving that? When the battery life was only about 8 hours, completion rate was not so good. So prokinetics were used to help in better the completion rate. But now with the battery life of about 12 hours, there is no need to use prokinetics. And It need only be used when the capsule has failed to exit the stomach after 1 hour. So at that time, it may be useful to give a prokinetic. What about the procedure? When the patient comes after preparation, 8 sensor arrays are placed on the abdomen and a belt around the waist. The data recorder is attached to the belt before capsule ingestion. The capsule is ingested with a glass of water and fluid is restricted till 2 hours after ingestion. After 4 hours, a light snack can be taken. Daily activities need not be interrupted, but exercise is avoided. It is good to look on real time and follow the capsule to make sure that it has left the stomach within an hour or so. If not, a gastroscopy needs to be performed and the capsule taken and deposited in the duodenum. Once the study is over, the sensory arrays and belt are removed. The images can be downloaded from the recorder to the workstation where it is processed, displayed, and analyzed. And what about the capsule? It is a one-time use capsule and passes naturally with the bowel movement and usually excreted in 24 to 72 hours. Are there any software enhancement to help analysis of images? Yes, there have been some enhancements. The first one that came into the market was the suspected blood indicator. The software actually highlights frames where there is an excess of red pixels, which may represent a bleeding lesion. But studies, however, has been disappointing with sensitivities as low as 20 to 25%. With such low sensitivities, it is necessary to completely review the study before giving a report. But however, the suspected blood indicator software may be a complementary to a complete study. A second software enhancement was a chromoendoscopy, where Fusionon, together with PillCam, came out with 5CE. But recent studies have shown that 5CE is no better than white light CE and therefore not very helpful. As you know, it takes quite a time to review the almost 60,000 images that are recorded. It takes anywhere between 45 minutes to 1.5 to 2 hours, depending upon the expertise of the reviewer. So it would be good if we could get some software to reduce the reporting time. And again, PillCam came out with a quick view, which makes capsule reading more efficient. What it does is it selects a certain percentage of frames as a reader and produces a condensed video for review. Though this reduces the reading time, there is an unacceptable high lesion miss rate of 8 to 20%. And therefore, again, it is often necessary to read the whole study. Can the duration of the study be reduced? The only way that it can be reduced is by using the real-time imaging, where you follow the image, and as soon as it leaves the comes into the cecum, one can then stop the procedure. So essentially, there are no good software enhancements which are ideal. Coming on to indications for capsule endoscopy. The major indications are gastrointestinal bleeding and iron deficiency anemia, inflammatory bowel disease, mainly Crohn's disease, surveillance for hereditary polyposis syndromes, celiac disease, and NSAID enteropathy. In a study from our center at CMC in 2010, when we looked at indications for the about 178 procedures that we did, obscure GI bleed was the indication in 3/4 of cases, and in 20% it was iron deficiency anemia, and in a few cases abdominal pain and diarrhea. When we look at another Indian study by Dr. Goenka from Calcutta, again he got the same result. Obscure GI bleed was the major indication in 76%, followed by chronic diarrhea and abdominal pain. We'll next go into each of these indications in a little more detail. We'll start with obscure GI bleed. The major etiologies that are detected with capsule endoscopy in obscure GI bleed are vascular lesions, ulcers, and small bowel tumors. The diagnostic yield of capsule endoscopy in obscure GI bleed is 61%, which comes from meta-analysis of 227 studies, including almost 23,000 procedures. You should note that the diagnostic yield in iron deficiency anemia is only 47%, comes from a systematic review of 24 studies. So the yield is much less in iron deficiency anemia as compared to other causes of obscure GI bleed. And the diagnostic yield is higher for overt obscure GI bleed as compared to occult GI bleed, 87 versus 68%. If a patient presents with an overt obscure GI bleed, you would get a higher yield if the capsule endoscopy is performed early, that is within 48 hours of the index bleed. This slide shows capsule endoscopy pictures of many of the usual causes of obscure GI bleed seen. This shows an angiodysplasia lesion, jejunal varices, portal hypertensive gastropathy, a jejunal polyp, and villus atrophy in celiac disease. In our series of obscure GI bleed from CMC, the most common lesion detected were vascular lesions, around 40%, of Crohn's disease in about 39%, followed by tumors in 8%. However, the study by Dr. Goenka from Calcutta showed ulcers and erosions in about 2% and vascular lesions in 9%. What is the reason for this difference? In fact, a very early series in 1998, before the advent of capsule endoscopy, from a surgical group in CMC showed that small bowel tumors were the highest in proportion. So what could be the reason? One could be the age of the patient. In patients less than 40 years, tumors, Crohn's disease, Meckel's diverticulum are the common causes seen, whereas in patients above 40, vascular lesions and NSAID enteropathy. So the age of the patient could determine the lesions seen, and also the group, like is it a surgical group which is reporting or a medical group reporting. But by and large, if you look at all the literature worldwide, vascular lesions are the most common lesion, followed by ulcerative lesions, followed by tumors. Again, what is the diagnostic yield from our Indian studies? The diagnostic yield in obscure GI bleed was around 75% in our study, and similar in the Calcutta study, which was 74%. But it should be noted, like I said earlier, that in our study we found the diagnostic yield in iron deficiency anemia was only 34% as compared to 75% when we included other causes of obscure GI bleed. What is the diagnostic yield of capsule endoscopy as compared to other modalities? Capsule endoscopy is better than push enteroscopy, small bowel follow-through, CT angio, angiography, and CT enteroclysis in the diagnosis of lesions in the small bowel. It is similar in yield, diagnostic yield to MR enteroclysis and double balloon enteroscopy. Next, does capsule endoscopy change management or alter outcome? Studies have shown, yes, in about a third or two-thirds of patients, the management strategy was changed based on capsule endoscopy findings. Another important point to note is if there is a negative capsule endoscopy in the setting of obscure GI bleed, the rebleeding rate after a negative CE is very low. So currently, due to good diagnostic yield of capsule endoscopy, the ability to change management or alter outcome, and the perception of patients that it is non-invasive and less burdensome, because of this, most societies recommend capsule endoscopy as the examination of choice when patients present with obscure GI bleed with a negative gastroscopy and colonoscopy. What would be an algorithm for evaluation of obscure GI bleed? If the bleed is massive, then an angiography is the choice of test. And if you find a lesion, then appropriate management to stop the bleed should be done. If it is not massive, then capsule endoscopy is the diagnostic test of choice. If you get a positive finding and see the lesion, go on to a specific management. If it is negative, you can do observation and conservative management, because as I said, the rebleed rate with a negative CE is very low. But if bleed recurs, then we can either repeat a capsule endoscopy, do a balloon-assisted enteroscopy, or if that is not available, an intraoperative enteroscopy. Going on to capsule endoscopy in inflammatory bowel disease, what are the indications? It could be used for evaluation of the small bowel in suspected Crohn's disease with a negative colonoscopy and imaging studies. The incremental diagnostic yield with capsule endoscopy is around 22%. If the capsule endoscopy is normal in this setting, it has a high negative predictive value of 95%, which suggests that if you have a normal CE in suspected Crohn's disease, then it is very unlikely that that patient has Crohn's disease. It is also used to evaluate mucosal healing during therapy, post-operative recurrence, and also to evaluate small bowel in unclassified IBD. What about the diagnostic yield? Is definitely less than in obscure GI bleed. The diagnostic yield is around 50 to 65%. But CE in inflammatory bowel disease is superior to small bowel follow-through and CT enteroclysis, and similar diagnostic yield to MR enteroclysis and double balloon enteroscopy. There are certain limitations. There are no well-defined criteria for abnormal findings, especially the small findings, erythema, erosions, ulcers, all ulcers, aphthoid ulcers. There are no good criteria that has been given. Inability to take mucosal biopsies is another problem, and retention of the capsule in structuralizing disease is a third issue. What about celiac disease? Positive celiac serology and negative duodenal biopsy. Sometimes CE can detect mucosal detail and villus changes in the distal small bowel. Also be used in refractory celiac disease, where it can identify serious complications like ulcers. Again, a major limitation would be the inability to obtain mucosal biopsies, and there is an interosseous atrophy. In hereditary polyposis syndromes, it is recommended for. It has been shown that in cohort studies that CE is better diagnostics, including MRE, especially for detection of small bowel polyps, perform therapy, and lack of definitive features to differentiate a mucosal bulge. What are complications of capsule endoscopy? It's a very safe procedure, very complication. And what is retention? It is not that if the capsule is there for a minimum of 2 weeks in the GI tract to call it retention. 0.4%. Again, it would depend upon the clinical situation. In intestinal obstruction and in suspected CD, again, it is less than 5%, whereas in obscure GI bleed, 1.5%. There are only 6 cases of retention. The retained capsule can be removed by balloon-assisted enteroscopy or surgery, and usually correct the cause of the capsule retention, like stricture. Can we predict what would be capsule retention? Agile patency capsule, again brought out by PELCAM. What is this agile patency capsule system with RF identification tag and an RFID scan as the real capsules? It has a cellophane wall filled with a mixture of barium and the lactose filling the capsule has a time frame. It dissolves the collapse of the capsule, which then can be excreted or passed across the stricture. The study has found that the patency capsule, CT enteroclysis, and a negative predictive value for capsule retention. Patency capsule is not much used in our country because of the cost. Make use of the MR enteroclysis if you really need to check out. Capsule aspiration is another rare losing procedures. The risk factors for this complication include old age. Most patients, they expectorate the capsule out, but occasionally it is aspirated. In cases with a high risk, it is better to directly place the capsule into the stomach in these patients. What are the contraindications for use of capsule? Very few. The main one is small bowel obstruction. Swallowing disorder is a relative contraindication, and when you suspect this problem, it is better to deliver the capsule or advanced CE device for US endoscopy. The advanced CE device can be passed through the biopsy channel, and the capsule endoscope can be held in this area of the delivery device. and the scope can be passed into the stomach or duodenum, and the capsule can be released. Pregnancy is a relative contraindication because of the potential for teratogenic effects of transmitted microwaves. What about small children? The US FDA has recently allowed use of capsule endoscopy in children as small as 2 years of age. The diagnostic accuracy is about 61.4%. What about pacemakers, implantable cardioverter defibrillators, left ventricular assist devices? In early days, this was a contraindication, but now there are robust studies which show that both there is no electronic or mechanical malfunction with these implantable devices, as well as it does not affect the video of the capsule endoscopy. However, telemetry can interfere with capsule endoscopy videos. Over the last 20 years, there has been significant technological improvements in capsule endoscopy. The battery life has become longer. And this has helped to improve the completion rate. Image capture frame rate has increased so that when the capsule travels faster, the frame rate also increases. The angle of view is wider and light control is optimized so that the pictures have become better and the diagnostic yield has improved. Many real-time viewing systems are now available. Esophageal capsule and colonic capsule has also come in. Not too much used in our country, and I've not gone into it in this lecture due to lack of time. There are, however, multiple limitations. There is an inability to control movement of the capsule in the GI tract. The accurate localization of the lesion and measurement of size of the lesion still difficult. Post-procedure processing of images needs improvement. There is an inability to obtain tissue for histopathological examination via pulpectomy, and the battery life is still very limited. So in conclusion, a safe technique for evaluating small bowel disease. It is perceived by patients to be more tolerable and less burdensome than endoscopic procedures or MR enteroclysis. There are, however, major limitations like inability to, as I said, to control movement of the capsule, acquire tissue for pathology, and perform therapeutic procedures. Improvements, experimental till now. There have been many technologies, but still, due to the limitations, there are many new experimental advances that are going on. These exciting experimental advances in capsule technology to become real and to come into practice in the future. Thank you.
Hello, everyone. My name is Jonathan Leighton, and I am a gastroenterologist practicing at the Mayo Clinic in Arizona in the United States. I would like to thank the organizers for inviting me, and I look forward to giving my lecture. And we are going to talk about capsule endoscopy for the future, and I will go ahead and start. It's been a very exciting time from the year 2000 when capsule endoscopy was introduced, and even today, new things are happening. We're going to focus on expanding clinical settings, advances in localization, imaging, and optics, propulsion, locomotion, and remote control, therapeutics, including biopsy and drug delivery, and then artificial intelligence. And if we start with expanding clinical situations, the acute GI bleeding in the emergency room has probably gotten the most attention. And for those presenting with hematemesis, capsule reduces the number of admissions and number of endoscopies. And even in non-hematemesis bleeding, capsule has been shown to improve the detection of the site of bleeding compared to standard of care. And this is likely related to earlier investigations, which improve the likelihood of detecting active lesions. And remember now, with the impact of COVID-19 around the world, avoiding invasive procedures and requiring PPE is definitely a good thing. Also, we're looking at using capsules more outside the GI suite. So for example, the capsule cam is ideal physicians who do not frequently do capsule studies. And these can be sent to a central reading laboratory with a full report to the referring gastroenterologist. And then there's even more data on using the capsule in intensive care units, hemodialysis suites, and even surgical suites. So a lot more to come. Let's not forget about colon capsule endoscopy. This is FDA approved in the United States for incomplete colonoscopy or patients who can't undergo colonoscopy. And the capsule takes very nice pictures of the colon, as you can see here on the right. And to give you representative pictures, you can see here what it might look like as it goes through. You obviously need to have a fluid-filled colon, and you need to have a good prep. But you can see here an example of a polyp seen on colonoscopy and then on capsule endoscopy. And the accuracy of the second generation capsule favorably compares to CT colonography. So very exciting opportunity. I also wanted to mention this robotic assisted colonoscopy platform with a magnetically actuated soft tethered capsule. And so it's a new painless colonoscopy platform that uses active locomotion. And the data so far looks very good compared to colonoscopy. And then finally, even more exciting is the C-scan cap from CheckCap, which is actually potentially a prep-free imaging. And it uses sonar-like technology for 3D reconstruction, as you can see here. And when the capsule moves, it does emit low dose radiation, but it is extremely low dose. And this shows you what the reading platform might look like. And so this, again, is also very exciting technology that I wanted to mention. Also, don't forget about the smart pill and wireless motility and pH capsule. Several studies which show that you can look at regional gut transit as well as whole gut transit using pill technology, and we'll see more of this in the future. Moving on to advances in localization and imaging and optics. This is also an exciting area. We have localization in 3 dimensions has been solved using radio frequency, but a lot is happening regarding localization in using magnetic fields. And in terms of strategies, if you want to understand it, the options are magnetic field-based localization, electromagnetic wave-based localization, and then there are other strategies. But this just gives you an idea of the area. Most of this is still being tested outside the human body. But in terms of magnetic localization strategies, there are examples of cubic magnetic array sensors, wearable magnetic localization array sensors, and even multi-coil electromagnetic tracking systems. And then if you look at the electromagnetic wave-based strategies, that examples of that are using radio waves, using RFID localization systems, and then also visible wave localization strategies using a cyber physical system for localization and distance traveled. So hopefully we'll see improvements in this area. Another great technology that's used for the colon capsule is an adaptive frame rate technology, which improves the ability to see lesions. If you look at this, you can see how quickly the capsule moves at 4 frames per second. But with this adaptive frame technology, you can see at 35 frames per second how much better you can see the colon and therefore not miss any significant polyps. So this technology is excellent. Moving on, we have improvements in imaging. One is the SIAC capsule, and you can see that this is a double structured capsule with an outer shell that protects the inner shell, and it can take 870,000 images generated at a rate of 30 frames per second. And then the images are processed into this mosaic image. So very exciting technology. And then I mentioned, and I think many of you are aware of the CapsaVision technology, which has 4 cameras separated by 90% capture images. And this is able to really work nicely for taking images. And you can see that it's a completely different look from standard capsule endoscopy. And this just gives you an idea of what it might look like as the capsule streams through the small bowel. But the nice thing is that this is completely disposable and no capital equipment costs, and it can be done at home. I also want to mention the capsule that I've had the opportunity to work with, which is a novel panenteric capsule, and particularly for active Crohn's, can examine the entire small bowel and colon. And so in our study, this was great because the patient can swallow it, and you can see the stomach, the small bowel, and the colon all at once. And this would really provide mucosal imaging of the entire GI tract in a single procedure. So very exciting. And then other advancement in the optics, we continue to see wider angles of view, more sophisticated lenses, multiple recording cameras, automated control of light, increased battery capacity, real-time viewers, and non-white light endoscopy, which I find very exciting. And this gives you an idea of FICE. What's nice about it is in channel 1, you can see how if you're not sure it's blood, it will bring out the red chroma. And the same thing here, if you're not sure if this is adherent material or not, you can see that it brings out the erythema associated with an ulcer. So I think that will help a lot. Another area that's very exciting is propulsion, locomotion, and remote control. And the current limitation of capsule is its lack of maneuverability, and it depends on gravitation and peristaltic forces. So as we look to better strategies, one is internal locomotion using a miniature actuator in the capsule, and then external locomotion or magnetic controlled capsule. And so this is an example of internal control where the capsule can propel itself using vibratory technology. And then this internal locomotion, though, is limited by technical constraints of incorporating this into the device, but there are leg, paddle, earthworm, and propeller-based technologies. But still, the clinical models are lacking, and interest has waned due to significant technical hurdles. But example would be this legged locomotion capsule that you can see that was tested in a porcine colon model. The external locomotion uses interaction between internal components and external magnetic fields. And it has been better studied in clinical settings. And the two main approaches are handheld magnets or robot-guided magnets. And this shows you how powerful the magnet is to control the capsule. And so in this case, this is the Miracam Navi, which is a magnetically assisted capsule endoscope with this apparatus. And you can see here, they're showing you how this might work. And in clinical studies, it did very well compared to upper endoscopy. And you can see here that in this particular study of this capsule, you get very nice pictures of the stomach and even the Z-line. Moving on to robot-guided magnetic capsules, it replaces the human controller, as you saw in the last picture, and improves procedural precision, as well as procedural time and diagnostic yield. And this Navicam system uses a joystick to manipulate the C-arm. And again, shows you very nice pictures, not only of the Z-line, but also of the stomach. And this shows a detachable string magnetic control capsule for the esophagus as well, that lets you get a good look at the esophagus and then move on to the stomach. So what about therapeutics such as biopsy and drug delivery? Also very exciting. Imagine if you could have a capsule that could be remotely controlled to deliver therapeutics wherever you want, and that's being looked at. You first should know about optical biopsies, which are optical biopsies where a diagnosis is obtained without tissue acquisition using artificial intelligence, and it has been tested so far. And there are several examples, such as the compact photonic explorer and the tethered capsule with a fiber optic laser scanner for Barrett's esophagus. And then there are technologies with spring coiling to take biopsies, actual tissue biopsies using spring-loaded devices. So all very exciting. And one of the projects that's ongoing is something called vector capsules that have the ability to do exactly this, to take biopsies. Now, drug delivery systems are even more exciting, but still very experimental. They can deliver about a milliliter of medication through extended release or modified forms. And the advantages are smaller doses of drug, as well as optimal therapeutic effect with quicker onset. And there are two main categories. There are those that are looking at micro electromechanical systems and those that are non-mechanical. And examples of these microelectrical mechanical systems for drug release include the telemetric capsule that uses a radio frequency pulse to generate a current that heats a filament until it melts, releasing a needle which pierces a balloon to release its contents. Very exciting. And then the IntelliSight capsule and the Interion capsule that also are designed to deliver a wide range. And Interion has actually been studied in human subjects with active dispersion of the drug and no serious adverse events. And then there's also the iPill, which I show you here, which has a sensor that detects acidity and temperature and can react to pH changes. And the reservoir has a tiny pump that can deposit medicine at a specific location, either all at once or in bursts. The non-mechanical drug delivery systems have not been as successful. It's where you have a chemical interaction with the environment to release the drug out of the capsule using pH or temperature sensors. But the drawback is lack of control of drug delivery in terms of target location and rate of release. So we'll have to see if that continues. And then finally, I'm going to end with the area of artificial intelligence, which is very exciting. And there are a hierarchy of terms, and areas of great potential include polyps and masses, angioectasia or vascular lesions, celiac disease, and Crohn's disease. And these are decision-making or prediction processes, and capsule endoscopy is an ideal platform. And the process is where you classify the lesion, you detect the lesion, and then you segment it so that you can use it, and then you augment the images, and this gives you more data on which to base this. And in this very nice systematic review and meta-analysis of 45 studies, you can see that ulcer detection was very good, as was bleeding detection. And the importance of this is that these models can reduce reading time and miss rates for significant lesions. And so there have been several studies, but in this case, you can see that the small bowel capsule studies were looked at for polyps with 90% sensitivity and 79% specificity. And in this study, the neural model was 97% sensitive, 93 specific, and 96% accurate for polyp detection. And again, some work that I have been involved in is looking at automated localization of polyps using both 2D and 3D based deep neural networks, where you can mask the lesion and then use the segmentation to use for detection. And the same thing with vascular lesions as well. there are updated versions of the small bowel of the blood indicator that demonstrates the presence of 8 consecutive marked images, was 100% sensitive. But using this new CNN-based segmentation model, we can get very good sensitivity, specificity, positive predictive value, and negative predictive value. And again, this shows the process for detection, where you have the original still frame, then you have this annotated image, then the convolutional neural network, and then the this network approach on the original still frame to make this detection more automatic. And in the group I have been working with, you can see how this might work, where on the right, it picks up this annotation as you're reading it and alerts you to the possibility that there is blood there. So you can see how this would really make sure that you don't miss any specific lesions. And the same thing for Crohn's disease. You can see that in this study that the CNN model could differentiate normal from ulcerated mucosa. And even in this exciting stomach from this year, that showed that you could even accurately grade ulcer severity based on mild, moderate, and severe. So artificial intelligence is very exciting and has a lot of opportunity to improve our reading times and decrease miss rates. So I want to thank you for listening to my talk on capsule endoscopy of the future. We focused on expanded clinical settings, advances in localization, imaging, and optics, propulsion, locomotion, and remote control, therapeutics such as biopsy and drug delivery, and artificial intelligence. And capsule endoscopy of the future continues to remain very exciting. And I thank you all again for listening.
That was an excellent lecture by stalwarts Professor Ashok Chacko and Professor Jonathan. Professor Chacko, if you are there and you can unmute yourself, we have a good eminent panelists and chairpersons and good representation all over who practices enteroscopy and capsule endoscopy. So, sir, in your unit where you have all these facilities available, and what is your protocol on decision of capsule endoscopy?
Thank you, Anupama. As I had shown in my algorithm, for obscure GI bleeds, that's why we usually use a capsule. We first do an upper and lower endoscopy, and as you know, if you don't find, we call it obscure because it's negative. The next step, unless we have a massive bleed, is to do a capsule. This is what we do as the next step. And then depending on the finding, if we can choose the direction of the balloon-assisted enteroscopy and go ahead for therapy. We do not go directly for balloon assisted. We do a capsule followed by an endoscopic enteroscopy. I have no experience with spiral, but that's a new technique. I looked for studies to show whether there is any study comparing spiral with capsule. Unfortunately, there are no head-to-head comparisons. There are head-to-head comparisons with balloon-assisted and spiral is as good as balloon-assisted, except that spiral takes shorter time and is more stable for therapeutic procedures. So indirectly, when you look at it, maybe spiral would compare with a capsule for diagnostic aid.
But do you always ask for a small bowel imaging before going forward for a capsule endoscopy? Are you worried about capsule retention?
It depends upon the situation. Unless the patient has symptoms of subacute obstruction, I have not had any case where there has been a retention of capsule, even in Crohn's disease. So if they have any symptom or suggestive of symptoms, then I think we should be careful. An MR or CT enteroclysis is good enough to detect if you really want to do. And sometimes if you suspect that you're going to get stuck, we may not need to do it at all. We might as well go in with other endoscopy techniques. Now that we have many other endoscopy techniques, there may not be a need for balloon when we have a feeling that it might get stuck.
Sir, this is Dr. Sethi from Kolkata.
Yes.
I have two questions regarding capsule retention. We had 6 out of 385 patients in our series with Dr. Goenka, and we had to operate 3 patients. So just a thing, because it's a medical thing, if somebody gets stuck with capsule, and what do you explain, prior to the procedure, whether they need a surgery at some time? This is one question. Second is, some patients, the capsule, because of maybe gastroparesis, quite a time we see capsule is in the stomach, 2 hours, 3 hours. And in those patients, what do you do? Because we do see in the during the procedure, the capsule is not moving forward. So what do you do?
Regarding the first question, your first question was
capsule retention, and how do counsel or how do tell them if there is a capsule stock, patient lands up in surgery, and they might not agree for a diagnostic procedure, goes for surgery.
So, I mean, if you are doing a patient with Crohn's, and even if you have a slightest doubt, we have to tell the patient and document it. I think once the capsule gets retained, normally it comes out within 48 hours or 72 hours. But if you suspect it is still there, patient hasn't seen it in the stool, then you can fluoroscope, and usually we'll be able to detect the capsule. We don't have to panic, because what I normally do is then give them laxatives. Try to give them prokinetics as well as some peg leg. And usually what I find is it is excreted out. But we have had in all our nearly 300-400 capsules we would have done, is we have just had in the initial days about 3 patients whom we operated. And I think 2 of them we operated early because we got worried. It has been 1 week, 10 days, capsule hadn't come. So we were worried. But now we have enough, not only us, but we have enough experience to show that we don't have to rush in. We can wait. Even the definition of retention is that when a capsule is there for more than 2 weeks. And even for long duration, even years, capsule has been retained in a patient in the US where no other complication has happened. So there's no need to get worried. And now we have balloon-assisted enteroscopies and spiral with which you can take it out. You don't need to go in for surgery. So that is the first question. The second, more easy, is if it is retained in the stomach, we can go in with a Rothnet and take it and put it into the duodenum, or even a basket. You can take the capsule and place it into the duodenum. And now we have real-time viewers, so it is better to look at the capsule real-time till it goes into the duodenum. So that is easy to move out.
I got a question. I'm Dr. Ravi Shankar, sir, from Hyderabad. So do you prefer your technician read the scans first and then you prefer the gastroenterologist to read it next, or you prefer the gastroenterologist to read the pictures first?
In our place, the technician usually looks at it. There are ample studies. We haven't done any study in our unit, but there are ample studies of nurses looking at the pictures, noting down areas which they think is abnormal, and then the doctor reading. When I was in CMC as well as in Madras Medical Mission, our technician used to initially go through the study and select areas which he thought was abnormal. Then the doctor would go through and check the technician's finding as well as run through. This definitely saved time.
Yes, sir. So one more question. So in our practice, we have seen some patients who are having multifocal strictures. It doesn't appear like Crohn's and it doesn't appear like NSAID abuse, because the patient, there is no history of NSAID abuse. They just look like NSAID strictures. I think probably it's, we have been thinking it as a multifocal ulcerative stenosing disease. In your experience, how many times you have seen this? And recently is my observation that quite a few patients, 5 to 6 patients in the last 1.5 years, I have seen these type of cases.
Did you get retention of the capsule?
In one case, there was retention of the capsule. I thought it is Muse.
Not been a major.
Sir?
I didn't catch on the last bit that you said.
Multifocal ulcerating stricturing disease.
Small bowel, multifocal ulcerative stricturing disease. The most common, as we see, is Crohn's, TB, which is common. That's the one we see. Ischemic strictures sometimes is what is reported when obstructive small gut is resected and given to the pathologist. We get a report of stricturing disease. These are the usual things that we get, but I don't think it is I don't know what your experience, how often you see it, but from my experience, we hardly ever see this problem. And what we have seen has been usually Crohn's, if it is multifocal, coming throughout the small gut.
Yes.
TB is more towards the distal part of the gut.
The same thing, sir. With active ulceration, with strictures, we treat as Crohn's disease to all the patients. And one more question, sir. Some patients has had overt bleed in the past. You do capsule endoscopy and find not very specific lesions, only few erosions and nothing much, some mucosal changes. Then treating them is difficult because they had multiple blood transfusions in the past and got admitted. Now capsule is not showing anything much. Endoscopy is normal. So what should you advise them?
If one capsule has been done,
one capsule,
and it has been, you have not found anything on the capsule, and the patient is continuing to bleed.
The patient had a major bleed in the past, and right now is not bleeding. But then in that case, what should you advise?
Only one bleed they have had, or multiple bleeds?
Multiple bleeds in the past.
Bleeds in the past.
Maybe you are progressing the first time and you did a capsule endoscopy. That is coming near normal.
So it's very likely that the lesion has been missed by that capsule, because when movement of the capsule, it takes between 2 to 4 frames per second. Sometimes it's always possible that it has got only one camera, the small bowel capsule. So it is very likely that the lesion has been missed. So you need to repeat the test. I know it is expensive to use another second capsule in our country. So, but if the patient is continuing to bleed, you can go ahead either with a balloon-assisted enteroscopy or go in for surgery with an on-table enteroscopy. Because if there are multiple bleeds, definitely there is a lesion. If it is only one bleed, then I think you can follow up. You don't need to do anything.
There is no bleeding further. I think you can still wait and watch.
Yes.
If there is a bleeding, then you can do some intervention or imaging again.
This is Dr. Dinesh Kini from Bangalore. In a clinical situation where somebody comes with an overt bleed, not an occult bleed, endoscopies are normal. Do you think a CT and an enteroscopy is much more yielding, gives more value than doing a capsule endoscopy? This is in compared to somebody whose hemoglobin drops and endoscopies are normal, CT normal. In those groups, a capsule is likely to yield more result than subjecting them to enteroscopy. What are your views and experience on that?
Yes,
Thank
sir.
you, Dr. Kinney. If the bleed is not massive, I would still prefer to do a capsule endoscopy before going in for a double balloon enteroscopy, because it's a non-invasive procedure. It's easy to do. The yield to detect a lesion is high. And once we detect the lesion, if required, we can always decide the route of the double balloon enteroscope or single balloon enteroscope that we use. So in my view, I always prefer to use a capsule rather than a balloon-assisted enteroscopy. Second thing is, it's a very easy technique. It can be done in all centers. So if your center is very specialized in or is very adept at doing balloon-assisted enteroscopy, then you may go ahead and do it. But as a rule, I think both are complementary procedures. I would prefer what I would like to do is do a capsule and then follow it by an endoscopy.
I agree with you. I think, thank you, sir. We should close our session. Thank you very much. Thank you, the speakers, all the chairpersons and the panelists. Over to Anupama, and we can move ahead to other sessions.
Yeah, thank you very much, sir. It was an excellent discussion, and I hope we'll see you again.
Thank you very much. Thank you.